Right, so welcome to Global Diabetes Insights. So today's conversation, I think it sits with just a powerful intersection of clinical expertise and lived reality as well. So because for you, James, joining us on this podcast, you're not just a person living with diabetes, you're a nurse. So something that you're probably going to dive deep and to tell us more how you do that. And also you completed successfully your fundraising goal or when you're doing a marathon for Breakthrough T1D former JDRF. So that was a success. So thank you for all that you do to make sure that we have these things that we are hoping to see a cure for type 1 diabetes. And we are hoping to see those things happening or coming up on board as we move quicker to it. Because yeah, there's much precision. So much things have happened in the industry on people living with diabetes, so much campaigns going on and also those organizations that are leading us on the forefront. There's been a lot happening. We are joined by James Ridgeway, a diabetes specialist nurse, an educator, a researcher, and someone living with type 1 diabetes. 2, 3 years ago, I remember when you reached out to me, James, you said that you were writing a book. Probably we'll talk about that later on the podcast. Briefly, just introduce yourself to our audience.
Thank you, Tino. My name's James Ridgeway. It's exactly as you said. I sort of live, breathe, as we both do, diabetes, but both from a personal and a professional sense. So I was personally first involved in the world of diabetes after the hard landing of type 1 diabetes, and that was back in 2012, and I was at the age of 24, and that really kind of, not straight away, but it led the way for me wanting to become involved in the world of diabetes, because I was studying my nursing at the time of my diagnosis, and I thought, I want to educate healthcare professionals about this condition and all forms of diabetes, but also help patients as well because of my role in nursing. And I'm very blessed to say that I presently do both of those roles. I educate healthcare professionals, and I'm a diabetes specialist nurse where I go into the main hospitals in my area of the UK in a city called Leicester, which is sort of midway part of England, ever so slightly north, but we call it the Midlands. And I do sort of inpatient wards, but I do a complex outpatient clinic where I see all different varieties of life of living with different types of diabetes as well. Very much, I'd say it's kind of 24/7, and never one to really kind of get burnt out by it being overwhelming. I think there have been times where it's been quite a lot to deal with from both a professional and a personal sense, but I do love it every way. And I think from the personal side, it's that community, it's that peer support that really shines through. And from a healthcare professional stance, it's making other healthcare professionals more aware of the condition and how to make patients' lives better. And then from myself, from looking after people with diabetes, it's able to make their lives a little bit better, live as long and fruitful journey as possible. So yeah, I think that's a nice start intro for me.
Well, thank you so much. That was brilliant. And I think it has somehow dived on the question that I wanted to ask you next in terms of like how you yourself as a person living with diabetes bridge that gap. It's something that we are hoping to see now as we are seeing more of diabetes advocates coming or getting involved in advocacy, also not challenging the system, yes, but maybe challenging the narrative. Also, whenever they get an opportunity to be welcomed by doctors so that they can also speak with some of the people living with diabetes, especially during the outpatient clinic. So maybe if you could tell us briefly, I think already you've touched on it, but if you could tell us how you yourself, from your lived experience perspective, the way you challenge those traditional models of care from within the system now, because also you visit and want to be part of those outpatient clinics and doing the things that we hope to see, because you don't just live with diabetes, but also you practice in the clinic.
Yeah, no, it's a good question to ask, Tino. And I think from my perspective, I kind of think back to my nursing studies and how kind of a previous, a long time ago, or even at the time of my training, there was a real focus, particularly in terms of doctors, on this medical model approach, where it's just purely based on, okay, results and what's the best interest according to the doctor or that physician for that patient, kind of centering on the physiological aspect of their health condition or health conditions. Whereas when I started to learn about nursing and in my training, I very much realized there's becoming this transformation shift, which become ever much stronger as I've gone through the years of my working profession in nursing, of this what we call biopsychosocial model. So we're not just thinking about physical health, we're thinking about how's the person living with their condition and general well-being from a psychological stance and also a sociological stance in terms of how it affects their environment and their friendships and their families. And that really goes well, and I think is best adopted, certainly in the outpatient clinic and also in the inpatient settings, I would say, because the first thing I would say for that person is how's life, not how's your glucose level straight away. Because if I know that life isn't good, then I know, or whatever aspect of their life isn't good, then I know that it's likely that the diabetes won't be as great for them in whatever form. And I think that goes into this holistic approach of managing and advocacy for the person. And you mentioned that word of advocacy, and I think it's really important. And the advocacy could be that of the healthcare professional, but what we're seeing more so is from other people with lived experience, so such as self, Tino. And I think advocacy stems from a few different places. So we've got people that have a lot of advocacy for peer support and community engagement. You've got advocacy in terms of policy as well, technology advancements close to myself, well, not so close in terms of the nation, just above England in Scotland. There's a real push and advocacy around technology as well in certain areas, which I'm sure you're aware of, but there is certain deprived areas of the world. There's real advocacy of making sure there's insulin for all, because like I use hybrid closed loop technology and I get free access to treatments and medications, but that is a real, I don't know, it's a real strain in a way, because there's people that struggle to even access insulin. So I think advocacy is hugely important from the point of clinic, when you're seeing that clinician speaking for you and with you and making that right decision, but then you have advocacy from those that live with the condition that really shout out what's in the best interest for themselves and their community. So I think advocacy plays a huge part. But if you're a clinician listening, I think the best approach for supporting people with type 1, type 2, type 3C, MODY, LADA, etc., is to really think about how they're doing generally in life at this moment in time, what's happening, and then talk about the diabetes and what they're finding hard at this moment in time, what's going well for them at this moment in time, and real support for them. And that thing of language, I think we're touching upon later, is quite important, and it goes hand in hand in terms of the advocacy from both clinical and personal perspectives.
Thank you so much for that, James. And I think I love the way you're blending everything in to say we don't just talk about how is your diabetes, but you also look at the other aspect, which is far much more important, but mostly it is neglected. We talk about life. When they talk about life, if life is good, definitely to transcend, we'll probably see that probably the diabetes management itself will be great, right? Because we understand much about life and they see that you care, not just about the numbers and everything, the time in range, the HbA1c's, those metrics. Not that they're bad, they're good. Yes, those are the things that we are using to measure up to see if someone is responding well to the treatment, or to some extent the words that they love to hear, like especially in clinic, something that the community is trying to move away from. They're trying to educate the healthcare professionals, the system, challenging everything. Say, let's not talk about adherence to treatment. Let's not stigmatize things. Let's not use those words. Language matters. Yes, of course, it does. We don't want to talk about that. I think if you could talk about some of the real cost of the neglect of the things that are not really prioritized, especially when someone present themselves when they're coming for checkups, especially in hospitals. We know of the things that probably should be prioritized, but they are not. I had somebody, when I asked, what is it that you wished you knew? Then they said, I wish somebody had told me that taking care of my mental health or also seeing a psychologist was important as seeing an endocrinologist. Some people have never been to a psychologist, but we know some of those things, there's a huge cost because of those neglects. So if you could share with us, you from your perspective, we have that lens from you, learning from your expertise in clinic, not just your lived experience, but you could definitely be our ambassador. You speak for us, you represent us well. And when you're sharing and you're educating your healthcare professional counterparts, you are sort of like have that understanding. And I feel like the people that you work with, they're blessed because we have that blend within you. So if you could tell us, so that maybe those that probably do not have access to people like you, they could learn something. We want to educate, we want to inform, we want to encourage and to help change this said narrative.
Yeah, of course. No, I think you've set the scene nicely for this particular part of the discussion. Is often missing, and it goes hand in hand with this report that came from Diabetes UK. I think it was 2021, which is called Too Often Missing. And it's something I was the pleasure of going to the Houses of Parliament with Diabetes UK for. And it was a report that was all about how there is a lack of support for people with diabetes from their mental health. And even at the point of the clinician asking the question of how are you, something that basic, but even if there is a problem, there's still that lack of support in clinics as well. For a healthcare professional, advice to another healthcare professional, probably one of the most important things is discussing how the person is from a psychological perspective, because it's one thing to live with a physical condition. Even when I was diagnosed, we got told about, oh, you need to do your annual screening, you need to attend these appointments, you need to take your insulin. As a person with type 1 diabetes and a person with type 2 diabetes, you'll need to take these certain tablets or non-insulin injectable therapies at some point, and potentially insulin as well. I was never told about the impact and the importance of psychological well-being. And it's like a cog, because if one's psychological well-being is impacted, it will impact the other cogs in terms of one's self-management, how they feel physically, both in just a general sense, but also their association with the condition. And then there becomes a lot of other steps into it as well. You could go deeper when we're thinking about TIDE, type 1 disordered eating, which has become more the forefront of type 1 diabetes, how we're highlighting how there's an association with misuse of insulin with the person with type 1 diabetes, because they see a negative association with that insulin and weight gain. And I've seen it a few times in my clinic where people have certain risk factors for it, both males and females. But that's quite extreme in a way, but it is very more common. But it all emphasizes the importance of us just asking the question of how they're feeling, what's going on in their life at this moment in time, and are they feeling distressed? Using the diabetes distress scale, you can do a 2 diabetes distress scale 2, and if it does elevate, so it has a high score, you can do the DDS 17, I think it is. From that, you'll be able to understand what elements around the management of their diabetes are they finding hard to live with. Is it the whole day-to-day self-management aspect? Is it the worry of hypoglycemia? Is it the worry about complications? Is it stigma? That's a whole new ball game as well, the whole around stigma, which I've been stigmatized, and Tino, I'm sure that you may have as well. Many people have, and actually people who are of certain ethnicity, so Black, Caribbean, South Asian, I think they have a 90% chance of being stigmatized from living with diabetes. And if they are, there's a 50% chance for those who are affected by stigma of not attending their following appointments. So for me, the thing that is missing, and there's 2 things. One is the maintenance and management of psychological well-being for the person with diabetes, but also how we can bridge that gap of community support beyond our clinical support as well, because we only see at best people with diabetes around 1% of the time each year for that person with diabetes, which leaves a huge amount of time for that person to be alone self-managing the condition as best as they can. So in that 1%, we've got to do the best we can. And part of that is trying to manage, assess, and support the person best we can from a psychological well-being perspective, as well as the other avenues as well.
We cannot thank you enough for all the things that you know, the things that you're doing, especially in clinic, leading from the forefront, not just from the sidelines where we're just speaking of the things that are not right for us, but nothing we can do about it. But also you're also like from an informed perspective, because some of the things you're walking the walk, you're walking the talk, that kind of a thing. I think those are the things that we are loving. And some of the things, yes, of course, yes, you're privileged, you work in clinic. Myself, I, as a certified diabetes educator myself, I've been privileged to work also like with some of the two amazing doctors in Zimbabwe that I'm currently working with in those two hospitals where they're working. Unfortunately, it's just for kids rather, or children living with diabetes. Mostly I go to the outpatient clinics, and whenever there's need, I also get the opportunity to come and see some of the people living with diabetes within the wards, that kind of a thing. And we are following up, trying to educate and everything like that. So which is smooth. How I wish that was available to everybody or for everyone. And I know there could be other people, other hospitals. You see, we celebrate so much when we see other people living with diabetes, when they become doctors, becoming nurses like yourself, pharmacists. We know something is will definitely get right. Hope that these platforms will continue to be there. People living with diabetes will be leading, not just challenging, but walking the talk, so that we are not just telling people, advising people to say, this is what you're supposed to do, but you're already doing it. You're actually doing it. And people will see how that is impactful, especially when we're seeing that even within the metrics that we are using, we would definitely be seeing some improvements. If proper diabetes registries are being maintained and collected, we'll definitely see that there's an improvement. And the engagement of people coming to those clinics, for example, it'll be fantastic. Because I've had a moment in time, like there was once upon a time, there were some people who told me that the reason why they were no longer coming to clinics, whenever we were just following up, chatting, they said it's the language that the doctors use. They are sort of like judgmental. Whenever we come to clinic, they'll be like, you're not managing a diabetes, so that is a poor management. You're not doing things right. Which actually takes me to my next question of what I wanted to ask, especially on the language matters. You yourself, you are a great advocate for this language matters issue. Of course, there's been a challenge and there's been an international consensus statement that were published thanks to the people that are leading this forefront. For example, there were people like Renza in Australia and so many other diabetes organizations came up on board also to adopt this consensus statement to say, I think this is what we need to see. We want to ask from where do you think we are failing? Where do you think we need to change fundamentally so that we see the change or we see the things that we want to see, that people also get that appreciation to say, yes, our doctors, they are so good. They speak to us nicely, even if things are not well, but they're not judging us. We approach things as they are. Yes, of course, we know we say that, yes, diabetes is individualized, it should be individualized. But then from your perspective, you, James, what can you tell us about this? Where exactly are we failing and what needs to change, especially on language matters issue? What can you tell us?
I like the way you set the scene with that question as well, Tino. There's a few things, and one thing that I just thought of is before I went into nursing, I was staff member, a carer in a care home, a residential care home for the elderly. I remember when some of people that were coming to the care home, they would look at different places and they said, oh, I've been to this really nice place looking care home, but I found that the staff weren't very nice. They didn't come across very nice. And then I've been to here, which doesn't look as fancy, but the staff are very nice and they seem very warming and friendly. And that's probably the difference. It doesn't matter what the appearance is necessarily, as long as the people are nice. And I think that works hand in hand in terms of how we support the people with diabetes and how the diabetes people like us want to be supported with by healthcare professionals, as well as other people with diabetes. It doesn't necessarily matter around the environment that you're in. It matters more around the way that the staff are supporting the people in those environments. Yes, you want the best places possible, the best research environments, the best clinical, most cleanliest places. But if you don't have as good quality of staff that can communicate in a really effective way, and we'll touch upon exactly what effective means, and part of that is language, then that's going to make very little impact. You could have ex-professor with really great research, but unless they talk to that person with diabetes in a way that that person can understand, in an empathetic way, in a sensitive way, it's very unlikely that well, I'm very doubtful that it will make a huge impact. There's some professors that I know, Professor Melanie Davies, Professor Prateek Chowdhury, for example, that speak really wonderfully with their patients, and Professor Claire Meek, who I've seen as well, very soft and gentle. And I think communication is key. And a big part of that is language. And you mentioned about Renzo Scabilia, and they were the real forefronters in terms of language. They did produce a consensus statement. We then kind of took all that on board in the UK, led by Professor Parthakar, who I'm sure you're very much aware of, Tino, as well. So the real kind of shouters on language were very much Jane Spate, Renzo Scabilia, and then Parthakar as well. And then there's been other people involved in the importance of language. And that's kind of transformed into not just diabetes, there's been language matters in obesity as well, which is really important where we're thinking about the increased prevalence globally of obesity, but also increased prevalence in type 2 diabetes and people living with obesity, as well as people living with type 1 diabetes and obesity. And it's really important to not necessarily label the condition with the person, like you're diabetic, for example. And I always like wince when someone calls me diabetic. I'm like, oh, no, I'm James, not diabetic. I'm the person living with diabetes. I remember I did a Twitter poll when Twitter was a real big thing during COVID. It's still a big thing, obviously, but we used it quite a lot during COVID. And I did a poll on language, actually, and asked the community how they like to be called. What do they associate the word diabetic with? And they came back with an interesting answer with the majority. And they said how they feel that it's fine for other people with diabetes to call them diabetic because they feel they have this lived experience. But for the healthcare professional, they should be asking that person what they would like to be called rather than just the assumption diabetic, because it's labeling the person. And in the Language Matters document, I would very much encourage people to read it, one for your own nation if you have one. But the UK has a very good one from the National Health Service, where I'm proud to be part of. And it talks about how we as not just healthcare professionals, but particularly healthcare professionals, could say something we don't necessarily think is harmful. It's like an unconscious saying that could actually leave a scar for that person. And I felt it in clinic as well when someone said something to me which isn't great language, and it really does hit home. It's hurtful. So, and they give really good examples of ways of being empathetic, supportive advocate, but ways of helping that person. Examples of bad language, less suitable language, and more suitable language for that person. I think the key thing is always thinking about empathy for that person as well. Thinking if you were inside their shoes or walking in their footsteps, how would you feel in that situation? And there's a real good video from Breen Brown on YouTube. It's worth looking at it because it's called Sympathy versus Empathy, and it shows you the difference between the two. And I think sometimes we can get a bit mixed between the two itself, where we think we're being empathetic, but actually we're being sympathetic, and it can actually make the person feel worse. So for me, language is hugely important. And again, it comes back to that whole thing of how we communicate. And a real problem that I see, where you mentioned, Tina, about what we're missing, I think it's around, again, I'm a big part of it, is education. And I think education in grassroots. So education when we're thinking about medical training. So doctors and myself in nursing, very, very limited education or amounts of time around understanding the management of diabetes and the language and the communication. It's more things around what is the condition in a physical sense, and not necessarily around that biopsychosocial aspect, and also most importantly how to communicate with a person with diabetes. I think that's an important thing that needs to change. But at this moment in time, I think for any healthcare professional, the important thing is knowing how to effectively communicate. And it might be worth people, I don't know whether they can or not, recording a pretend consultation with someone, like as a dummy almost, and then play it back and then seeing, do they like the way they heard what they said there? Could they change that or something? But communication is key, I would say.
We couldn't have said it any better. So thank you so much, James, for that. You're navigating both worlds yourself. we ask what could be wrong? Where do you think you're missing the system? Where do you think this is wrong? What do you think we need to change? That kind of a thing, so that we can challenge the narrative, because we hope that this will inform so many other people that will watch this, or even healthcare professionals that will get to watch this podcast or listen to it, because it will stay there forever. With diabetes management, what is true today could be wrong tomorrow, because the research is continuously being done. But on language, I think maybe it's something that is probably we are failing to correct, maybe from the beginning, when the nurses, the doctors, or the healthcare professionals are getting trained. Probably if those things, the foundation is laid properly, things will definitely change. They up there when they get to that level. People like Professor Partha, Professor Chowdhury, they speak so nicely about this. I remember one time, and I caught even, I think, from Professor Pratik, you say that we don't even tell people living with diabetes to test their diabetes, because when you're saying test, it's something that is bound to fail. So rather we say people, you can check your glucose, for example. There were some nice words that he used that was so good. And I remember those were people that are leading from the forefront. Whenever you want to see something nice, people that relate nicely with people living with diabetes, when we want to bridge a gap, we normally go to those people. Even people like Professor Partha, sometimes you would say, healthcare professionals, you don't need to be gatekeepers, but you need to provide a guidance for those people. Probably they know the things that should be done. Just be there as a guide, but don't tell them. Like you said yourself, James, you said it's healthcare professionals that know how to communicate nicely, asking people how they would want to be described. For some people, they don't have a problem being called diabetic. Myself, I don't like it. There are some words that we even use in my vernacular
Mm.
language, but sometimes I don't even want to use them, because I feel like, wow, they're just too heavy, right? Or with all these things that we are doing, we are hoping that this could change, and also it could be better for everybody, because we are trying to empower them. We are not trying to make it heavy for them. Already it's overwhelming. Living with diabetes is difficult, because they say that diabetes, I remember from the American Diabetes Association, they provide this amazing standard that they give out to the world, to say that diabetes is a complex chronic condition that requires multifactorial risk reduction strategies to minimize, because it's something else. It's something that I loved reading. I was like, wow, this is amazing. It stuck in me. It never left. And I still have it. And I repeat it. And when I'm reciting it, people be like, are you reading it from somewhere? Where did you get those words? They are bold, but it's something. It informs. It is so good. I loved it. The diabetes is one. We are united because we want to see the same thing. It's all about good quality life for people living with diabetes, and also trying to empower so many other people living with diabetes wherever they are, no matter where you are from, or no matter where you're connecting from. You are one of those people that are usually described as delivering powerful practice changing education. What we would want to know, what are the most diabetes education programs that you are getting wrong? What separates information from true transformation? Because that's what we care about. We care about true transformation.
Yeah, of course. I love your storytelling as well, Tina. I think you set the scenes of everything really nice. So you're a great podcaster. I give like a slight backstory, nothing too long, but basically I have two roles in the NHS. So one is as that clinician, as that diabetes specialist nurse, but my main role is in diabetes education and research, mainly in the form of education, based at one of the quite a lot of people might know it, but the Leicester Diabetes Centre. And I'm part of one of the umbrella teams, one of the main teams in the Diabetes Centre called Eden, which has been in existence for over 10 years. I can't remember exactly how long. But our aim is to educate healthcare professionals, particularly those in primary care. So when we say secondary, it's the hospitals, primary care, it's the community like GP surgeries to doctors, practice nurses, etc., pharmacists. And our aim is to upskill them around diabetes. And that's something I have a passion for, is to help someone to go from where they are at the moment, whatever baseline they're at, to help increase their knowledge and confidence. And I particularly really enjoy it when you have someone walking into a room, because I really like face-to-face education more than online, but I still like online because I like talking to people such as you. I really like it when a person comes to a session and they don't know something about what's being taught, or anything to do with diabetes, and then they leave the session knowing a little bit more. And where I really try to put as much excellence into is around that passion of education, making them feel interested and excited to be there, but also knowing how we can take a textbook and a guideline and really put it into practice. And it helps that we, in my team and myself, are clinicians, because that's the way that we can transform care. Is not just by getting them to look at a bunch of slides on a screen. That's boring. After a little bit of time, maybe one or two is fine, but then for a whole day or half a day, that's not enough. You have to meet the different learning styles of the person. Best example I found, and we've gathered lots of data within my team in terms of identifying quality from both the person with condition, but also the healthcare professional. The one thing I will always remember is when I taught type 1 diabetes one day to primary healthcare professionals. The next day, this practice nurse who attended then saw in their clinic someone living with type 1 diabetes, and they said a big thank you for the training itself, because they said prior to the training they knew a little bit about what it was, but then from the training they felt like they had a deeper understanding and could talk to the patient a lot better, and they could provide certain ways of information, education, and check things out with them. So they felt like they could talk a whole different language with the person. Well, that was really great how one day they went from learning to straight into practice the next day, the very next day. And I think that's the whole purpose of education, is transforming practice rather than going out to a day, reading and learning something and then just putting it on the shelf. That's not, for me, education. It's about transforming practice, and I think that's something we do very well.
And I remember one time when we had, of course, it wasn't me who interviewed Professor Pratik. I remember one time then he said, what we learn, what I research, what I go about researching is informed from what I learn in the clinic. And when I learn something in the clinic, I go about and research more about it. And then when I learn something from the research, I take it back into the clinic and then apply it. It was
Mhm.
so good. I was like, wow, I wish all the doctors could do that. But it's very sad that other medical professionals who probably don't have much exposure. I don't know what could be the reason, what could be the limiting factor to that. There could be so many. Some doctors or some medical professionals already, they might have sort of like neglected research. What they've learned when they were becoming those medical professionals is what they're still using, is those things that they're surviving on, sustaining on, which is very critical, like especially for diabetes. It could be wrong, really. So whatever that is, you're informing people, especially now with exposure. People are reading, people are learning so much. There's so many things happening. And then probably we are saying that some of the things that are being recommended now, they are no longer recommended to anybody. For example, we see that mostly, I think, in low to middle income countries, we still see that some people are still using twice daily injections because they're still using the human insulin where they just have to inject in the morning and in the evening. Whereas we see like maybe people from the developed worlds are using multiple daily injections. If they're not multiple daily injections, they're probably on an insulin pump, hybrid closed loop, yourself and myself. I'm also privileged to be on a hybrid closed loop. It's very sad to even begin to think about it, that I could be the only one in Zimbabwe using that system. But of course, we know that there are some people who are on pumps and CGMs, but on a hybrid closed loop, we will definitely know because there's sort of like a community. People connect because you have to build it because I use the Android APS myself. So definitely you'd know how many and who else is using it. And I see so many people want to use it too. There's so much happening, especially with what you have discussed and what we are talking about right now, and the things that we are continuously learning, the things that we see, the things that we see that, oh, these are good, these are amazing. We see that there are those recommendations that are made. Some people, I think I remember one time, I think that was last year, with the one abstract that I was presenting, I was co-authoring with Dr. Tiago from Spain. His research, 90% of the research papers, of the research data on diabetes that has been made, well, I think it's more than 90%. Much of it is from the first world countries. But what is it informing? It is informing the world. Everybody else has to take recommendations from that. But the research was done maybe in Europe, was done in the US, was done in Australia, but it is there to guide people even from Africa. But there was no research that was done in Africa. Those things might not be realistic to us. We don't have enough tools to support us or maybe to get us to that level. For example, if you're recommending maybe an HbA1c of less than 6% to somebody in Africa who doesn't have a CGM, who doesn't have a pump, that could be, it's a mess. It's difficult to attain that or to achieve that or to get to that number, for example. There are those amazing clinical guidelines. They are made in the first world countries. ISPAD has amazing clinical guidelines. EASD has their own clinical guidelines. American Diabetes Association has got standards of care that they publish. They look perfect. They're amazing on paper to say if you do one, two, three things, you will get to this. Not there's no perhaps. If you do this, you'll definitely get to this. If you do well, manage well, you will not get any complications. But we see that that is not even correct, right? We know that even if you're doing well, I think now education and things are becoming clearer that regardless of how well you've been managing your diabetes, even if you had enough tools and everything, you could probably get complications. Of course, if you do well, probably you could delay the onset of those complications. But even if you're doing well, even if things are well, and we know that like with these clinical guidelines, it's not everything that people follow to book from whatever that is written on the book. It's not like that is what people are doing on the ground. So like as someone who is probably navigating those two worlds, yourself, James, where do you think there's a biggest disconnect between what is recommended and what people realistically sustain? Not just people from Africa because they don't have everything, but for everybody living with diabetes. If you could guide us on that one.
I'm going to take you to a presentation that I saw. I think it was either last year or the year before at this conference called the Primary Care Diabetes and Obesity Conference. And that's really good. And I saw Professor Sam Sadu, who I'd very much recommend getting on to this podcast because he goes out to certain developing countries. I think he's in Ghana at the moment, I think. He does a lot of research and he did a particular presentation where he spoke about exactly what you're talking about, that gap between equality and equity, and also how we have these standards of in terms of guidelines and how they can apply better for some people and less than others. And there was this picture. You have to find it and send it, and you might be able to find it and put it out in however you can. But it was these three children who were watching a baseball match. How one was taller, the oldest, and then there's the middle. I guess they're all, I'm going to say they're related, I don't know. But the middle one, the slightly younger one, who's less tall, and then the youngest one, who's the smallest. They all were provided with a stool. So they all were given the same amount of support. And lo and behold, the tallest one's row is even taller, could watch, and they were behind this fence, and the tallest one could watch the baseball match. The middle one, who had the step, could just peep over the top, I think it was, but they have to go on their tiptoes. And the smallest one couldn't even get their head over the top. And that's the point here in terms of the disconnect, is that even though we have these standards, it doesn't necessarily replicate to people in certain areas of the world. Because if we said, for example, in my country, now we've got National Institute of Clinical Excellence guidelines, NICE, and they particularly revolutionized their approach for type 2 diabetes. How they say if a person with type 2 diabetes is diagnosed, then dependent on their condition, they would start on metformin, then an SGLT2 inhibitor, and potentially a GLP-1 receptor agonist, depending on the condition. And that's great. And that's thinking about helping to reduce the risk of complications. However, we have to think about how that's going to relate to people from certain ethnic groups itself, because we know and people from certain deprivation as well. Even in our own country, people find it harder to attend appointments, depending on the environment they live in. It might be transportation issues, it might be family responsibilities. In the NHS, we're very blessed because we don't have to pay for our medications. Certainly if you live with type 1 diabetes, for example, you get a medical exemption. But in other parts of the world, you have to do insurance. Some people can't afford the insurance. Therefore, they're missed out on certain treatments and things. Even though we have these guidelines in place, they're not suitable for all because they don't meet where that person is at that moment in time. And then that will, I don't know, increase the risk of those complications even more. What would help is kind of going back to that analogy, and where you had the first child with the lesser amount of stool, still the support in a way that allows them to reach over and look over, the middle one with even more support if needed, and the last one with the highest amount of support, which shows that for those that live in the most deprived areas, the ones that are impacted by cost the most, the ones that have family issues and secure issues and food deprivation and all these things, they're the ones that need the most support out of all of them, to be honest, to ensure that we're giving them the best treatments as possible. Yes, you have a standard that you have to meet the standard for everyone, because that wouldn't be fair. But we're not being fair for everyone if we're putting everyone on the same pedestal, because one size does not fit all at all. It would be amazing to know how many people are on a hybrid closed loop in Zimbabwe, and if you are the only one, I think it amplifies where we are in this world in managing diabetes and other health conditions as well, where we have these guidelines, but yeah, it doesn't meet the needs of everyone. Because if we're able to give support at right levels, at right places for each individual, then everyone would be on a hybrid closed loop system living with type 1 diabetes. And everyone with type 2 diabetes would be on a remission program or on a GLP-1 receptor agonist or whatever it is at that point in time that they need it most. I think we're getting there, but we're nowhere near there. As to how we get there is another question.
I remember putting on a thread, talking about this very issue to say, even for people with everything, sometimes it's even hard to attain that. This issue to talk about one size does not fit. I don't know if people really understand it. It's like a parable with a meaning that is difficult to comprehend because it doesn't seem like we actually understand what that means because we have been saying it. It's different. Yes, of course, like we said, those clinical guidelines, they're good on paper. But in terms of implementation on what is actually being done, probably the doctors that are making these recommendations, but they're making them for people living with diabetes. I don't know if they really consider everything, put everything on the table about equity. I remember using that analogy one time when I was speaking at this other conference. We would have failed on equity if one person who is in the UK is getting amazing care, amazing everything. They actually get phoned by the hospitals to say, come collect your diabetes management, come and collect your insulin, come collect your CGMs and sensors and everything, and also extra test strips. But for somebody in Zimbabwe, they are not getting the same things that you're getting. If they want to get insulin, for example, a basic thing, they have to pay for it. Already we have failed on equity. Your government needs to replicate or maybe copy what is working there because it definitely for people living with diabetes in the UK, they probably live much longer because their systems are designed to help people, meeting people where they're at, not like for them to come to you. It will not work like that. Health should just be a fair thing and a free thing so that people can attain and get the things that they need. I like countries like Denmark, for example. They charge so much on taxes. Time I had a conversation with this amazing, amazing doctor because I pay high on taxes, but I know that if somebody gets ill, not just me, but for anybody, a local person or a local citizen in Denmark, if they get ill, they're definitely going to get medication, free everything. Everything will be provided because we are contributing towards that. That's why we get proper services because people are paying taxes for it, right? So that is amazing. We need to see that people who might not be in a capacity to work, they are also getting some medication, for example. That is good. That's a basic thing. We thought those things could be free for all, like the way they begged people, encouraging people get COVID-19 vaccinations. It should be the same way they managed to get those, to procure those medications or those vaccinations for everybody. That should be the same effort they put towards getting medication for everybody, not just people living with diabetes, but for all other NCDs, so that it'll be fair for everybody. And we could probably be saving for something. Because when my friends, I remember when I was back in school, when I say that, I think diabetes taught me to be extremely responsible. Because when my friends, when they get pocket money, when they are saving towards maybe spoiling themselves on a weekend, I also always have to remove certain percentage to say, I think I'll put this on savings. Just in case our school hospital may not have medication, I need to be able to buy it myself. Already we are studying on a minus where other people are studying here from maybe the third floor. I'm probably studying from ground level and I need to climb using the stairs when other people are climbing using elevators, escalators, whatever that could be. Or maybe some people are on rockets and we are still using what? Donkeys. to travel. That is just it's just too much. The
Mm.
issue to do with equity is amazing. I think you've put it beautifully, and thank you so much. This is one of the best questions that I wanted to ask you, James. Why they are still treating peer support as sort of like an optional thing rather than an essential thing. We know that it is very essential. Some doctors know it, and especially doctors or medical professionals that work with other people living with diabetes that help them to bridge the gap. They're actually seeing amazing results, good clinical results for the people that are living with diabetes. Whereas for those people without or medical professionals who do not emphasize more on peer support, those gray areas will see them.
I think peer support is one of my key areas in terms of advocation, and I'm a true believer in its value and its purpose and its importance and its benefits in diabetes, but also in other NCDs, as you put it, so non-communicable diseases, so long-term conditions. And peer support has been certainly in my country for quite a while, but it's underutilized. It's been described as underutilized in my National Health Service. There have been some conditions that have done a really outstanding job at embedding peer support in service provision. One of them is mental health, and they employ in my local, or they did, I hope they still do, is they employ people who have lived experience with depression and other mental health conditions to be part of the service itself, to support people who are being diagnosed or struggling and living with a health condition. Now, sadly, we don't seem to have that replicated in the world of diabetes, which is a real shame, considering that diabetes is one of the highest prevalent conditions worldwide, and the increasing population and increasing mortality rates as well, and its association with other long-term conditions, including mental health. So for me, it's baffling to know why there is this still lack of peer support. It's all, majority of it is voluntarily done, which I think is good. And I think there are avenues of that have to be developed and kind of ongoing from a voluntary status, because I think that its true nature does come from the kindness of the community. I think there has to be this fundamental, what I dream to have is there to be some kind of peer support within service provision worldwide. And I myself led and created a peer support group for the past 3 years. It's now kind of being led by the community itself, and it's called Podding Peer Support. And it's mainly for people in the community, my local community, who are using an insulin pump, a certain insulin pump. And it's absolutely brilliant. And all it is it's mainly done with a WhatsApp group and messaging as well. And there was initially this hesitation from my local service, but once they saw it up and running, they saw the value in it. So peer support doesn't necessarily have to be costly. It just has to start with passion. But a lot of the time, that passion needs to be met with time and also funding for people with diabetes to be involved in it. But if you have that passion in supporting an advocacy, such as ourselves, then I think it goes a long way. In the country up north in Scotland, they do employ people with diabetes to be involved in peer support. And there's charities like Diabetes UK that have young leaders as well, real advocates as well. I think the challenge is that there's no real kind of hard and fast rule. What is a peer support intervention or into a group? There is more and more sort of advocacy in there in terms of there's a type 1 diabetes peer support best practice model created by, again, Professor Parthakar. And that's great. But in terms of its true impact, I think that's still questionable. I think it gives a good guidance of what makes a good peer support intervention, but there's just not the funding. And I think that's a real thing that's needed. So I think there is potential to make the best use of peer support. But at the moment, we're not doing enough. And it has a real impact when it is used, as I'm sure you know as well, Tino.
That speaks volumes, and that means a lot. We are part of this amazing diabetes online community, which is huge. There's so many groups on WhatsApp, there's so many groups on Twitter, Facebook, everywhere. Sometimes they're private, but of course, you're part of something, right? Some people connect from different parts of the world, different time zones, and we make time for it. But yes, we are learning something, and we believe that yes, peer support is amazing. It's fundamental. Everybody should be part of something. It's actually said that even for myself, living with diabetes since 2010, I only got to know that there were other people, other peers, my age, that were living with diabetes after 9 years living with diabetes, or the people that I took reference to, or the people that I never looked up to them, but those people that supported me were people living with type 2 diabetes. Not that it was bad, but then they were adults, all of them, because I didn't know about hypos. I would always go to the hospital for outpatient clinics whenever I need to go for review. My parents didn't know what was happening to me sometimes because they thought maybe Tino was just resting, especially on weekends. That's when I woke up with the hypo, with severe hypo. Sometimes I would be passed out already because I didn't know what was happening. I didn't know that I needed to snack as often, and we didn't have a CGM for all that matter. Probably I might have checked my blood sugars and seen that it was a 3, but I didn't know what to do, what action to take. I probably never felt hungry at that time, and then I would just go about doing my business. If I see a 2 now, like on my CGM, I would act promptly because I don't feel my hypos. A story for another day. But to take you back, like I think this will be our last question to you, James. There's been a lot happening and you've said so much. We cannot thank you enough. And I think there's something that we is always maybe asked of us, always encouraged of us for people living with diabetes, for advocates, people that speak for other people that represent so many other people, that you need to be resilient as somebody living with diabetes. We know that, yes, people living with diabetes are often labeled as resilient, which is a good thing. We want you to help us that sometimes, yes, we know that there's a lot that goes into advocacy. There's a lot that goes into advocating for other people, even for yourself, speaking up for anyone and for yourself. There's a lot that goes in there that probably you might not see. We want you to talk about when that same resilience becomes a burden rather than a strength. Sometimes it's not a strength. We deprive ourselves. Sometimes we get overwhelmed, but we continue going because somebody wants us to do something, or we just feel like, yes, good. We don't even take breaks for ourselves. We don't even take care of ourselves because we just want to be there for them. So if you could tell us about that as we close.
The word resilience, I think, hits home for myself, and you said it, and I think for many other people with diabetes. But then that itself, that resilience does start to dwindle away after a while for some people, depending on what's going on in their life. And I guess a word that comes to my mind when that resilience becomes over resiliating, if that's a word, is for the word that comes to me is fatigue, tiredness, particularly if you've got your fingers in many different pies, from advocacy, from supporting other people with diabetes, family life, you've got complications, if you've got a real issue with other things going on related to diabetes or not, you have to keep going. Obviously, you do in managing a condition, but as time goes on, that can lead to an element of that diabetes distress, can lead to burnout, can start to feel quite fatigued as well. And I think that because it's such a hidden condition, many people don't see everything that you go through from a daily basis, on an hourly basis. We think about that 180 decisions extra per day compared to someone who doesn't live with type 1 diabetes. All those really important decisions, no matter how big or small they are, can really wear a person down. It might be 180 for someone one day, but it could be 360 for a person another day. And then that person could be judged based on the past 14 days of their CGM report, or the last HbA1c, or the last week of their glucose levels, and not necessarily think about the whole effort that they themselves have been doing for however long since their last appointment or the last time they spoke to someone. And I think we don't give ourselves, certainly when we're talking about our own selves as people living with diabetes, we don't give ourselves enough pat on the back, particularly if you're not going, yeah, exactly, Tina. If you're not attending hospital appointments continuously, if you're not in the emergency room all the time, and if you are, it's because something's going on, and it's not the first thing we don't think about is it's your fault at all. So I think we can be very hard on ourselves when we are living with the condition, because we think, oh, we're not doing well enough, we're not thin enough, we're not healthy enough, we're not this, we're not that. But actually, what we have to think, what are we doing right in this world? What are we doing well? If you think about it, many people have got probably their own families, work life, and all these things, and volunteering, whilst living with a condition the best they can. And I always think back to the saying, and I say it in clinic at this moment in time, you can only do the best you can with what you have. And your 100% one day might be 70% the next day, but that's still 100% of your effort. And I want people and healthcare professionals to think that is that people with diabetes don't start out in this world wanting to develop diabetes, no matter what type it is. And when whatever type of diabetes develops, generally trying to do the best they can with what they have. And I think we have to just give ourselves a pat on the back, as well as the person, the healthcare professional, be as supportive, encouraging for that person so they can leave the clinic room with a smile on their face. And if there's no smile on the face, or a tear of happiness following it, I don't think we're doing a good enough job.
Thank you so much, James. Thank you so much. 100% today could be a 70% tomorrow, but that's 100 from what I'm giving. There's a lot that I'm also participating on. There's life after diabetes. There's life before diabetes. So, James, thank you so much for your honesty. Thank you for your courage, and thank you for your unwavering commitment to challenging the system, from caring and also living with it yourself. This conversation reminds us that diabetes is not just about numbers, like you said. It is also about the people that you're seeing, asking them about their lives, like you said yourself, James. How is life? Then if they give a positive response, then that would definitely translate to your diabetes management. Is this also about language, the dignity, and the systems that we choose to build? Let's continue challenging this system. What would be your last words?
One that I've been meaning to say quite a while, and I keep forgetting it, but I remember it. And it's what I say in my education, particularly when you talked about the numbers. My saying is don't think about the result, think about the journey that the person has taken. Because in terms of CGM language, if they're not meeting their time and range target, so what at that point? Where have they come from? Maybe they a big improvement from the last time. Or if things haven't gone as well, what's happening in their life? And don't judge them in a negative way. And don't just base management on one HbA1c result. Think about the trajectory of things. Think about what's going on in their life. So think about the journey, not the result. And that's what I would say.
Beautiful. I couldn't have said it any better. And I think even to our audience, if this episode challenged your thinking, well, that's exactly the point. The future of diabetes care depends on how willing you are to listen, to change, and to lead differently. You should be able to listen from our other people, even your people living with diabetes that you see, even for healthcare professionals. And also, I think I'd love to say that even for people, continue stay engaged, stay informed, and continue getting encouraged. And if you feel you need to ask questions, please do ask them. For some of the things that James is involved in, the peer support group that is part of, probably from other people who are in Leicester that might want to connect because he loves those face-to-face connections. But of course, he has no choice but also to connect with us online because that's the only way we can, right? So thank you so much, James, for everything and everything. And also to the people that watch this, we will continue to give you things like this. So thank you so much, James.